Welcome to Future of Caregiving.
When I was a second-year medical student, in our last quarter, we actually started our rotation. And on rounds one day, the attending physician said, yeah, biopsy came back. This guy's got cancer. It's inoperable. And he told me, the medical student, at the end of his second year, he said, go in and tell him.
Wow. Dr. Bruce Chamberlain is a hospice and palliative care physician. He has worked on a national level with organizations that influence policy and others that provide more direct local patient care. He believes there's a lack of understanding among the public and many physicians about what hospice and palliative care has to offer, and that lack of understanding is a major factor in limiting access to these important services. Dr. Chamberlain attended Johns Hopkins University School of Medicine and then completed his residency at Walter Reed Army Medical Center. Hi, I'm your host, Leah Warnke, and this is Future of Caregiving, where we explore the rapidly evolving world of caregiving. From technological advancements to demographic shifts, we'll delve into the challenges and opportunities that lie ahead for those who provide care and those who receive it. Join us as we discuss the future of caregiving with experts, care providers, and those with first-hand experience. We'll examine the trends, breakthroughs, and innovative solutions that are shaping the way we care for each other now and in the years to come. To start us off, do you mind telling us just a bit about your work now and kind of how you got there, your academic and career journey up until now?
It's been a strange course. What I'm doing right now, I'm working with a privately owned company that provides a gamut of services directed at elderly and disabled. So my particular area is inpatient palliative care. So I'm working at a hospital down in Rock Hill, South Carolina, where I work with two excellent nurse practitioners, and we do inpatient palliative care consults. We also are affiliated with a second hospital that's a little bit north of Rock Hill, where mostly it's me that goes out if they have palliative care consults. So I love what I'm doing. I've been doing it for almost 6 months now, and working with great people. It's a very rewarding position. The company also does house calls, so they have nurse practitioners that go out and visit people who have challenges in getting to see a primary care doctor. And we have an outpatient palliative care service who's supposed to be able to go out and kind of address some of the palliative issues, the conversations about end-of-life care, more aggressive symptom management than many primary care folks are comfortable with doing. And of course, there's also an associated hospice, and I work with them as well. How I got here is, as I said, a little convoluted. I went to medical school, Johns Hopkins Medical School in Baltimore. I did that on a military scholarship. So I was in the Army and went to what was then an excellent place, Walter Reed in Washington, D.C., and did my internship and residency in internal medicine. My dream was actually cardiology. I loved doing cardiology. Just the whole process, everything about it was excellent. And I had several very good mentors in that area. And so when I graduated, I was actually accepted into the cardiology program at Johns Hopkins. But the Army decided that they actually wanted somebody doing primary care down in Georgia, and that derailed that whole course. Did my time in the military, went out into private practice as an internist. And in the course of that practice, I saw a lot of geriatric patients, and I saw that one of the biggest issues with geriatric patients was chronic pain, that they were functionally and socially and emotionally limited by chronic pain. And, chronic non-cancer pain is not very sexy. There's not a lot of money involved, and people didn't treat it. It's like, here's your hydrocodone, good luck, go on. And I just wasn't satisfied with that. So I did some self-education in non-invasive pain management, and then I connected with the physical therapist and also someone who did invasive pain management, and sort of, I guess, unofficially started doing a lot of non-cancer pain management. And I saw some really remarkable success. Just some elderly folks who's only, I had the lady that has always stood out in my mind was this elderly lady who just had very bad arthritis. And her dream was just to be able to go and walk around the grocery store because that's how she socialized. But it hurt too much to do that. So she wasn't ambulatory anymore, and it was just devastating to her. And I got her on some good medicine, got her over to physical therapy, and I'll back up a little bit. The first thing that happened with her is when I said, you know what, let's work on this. I think maybe we can get you better than you are right now. And she just broke into tears because to that point, nobody had ever talked about really helping. It was kind of like, let's put a Band-Aid on it. I'll give you some, why don't you take some Lortab and good luck with that. And it was kind of tragic, but we got her back to shopping in the grocery store again, just with better pain management, some extended release products and some physical therapy to improve her strength. And that was really kind of something that said to me, all right, this is just a whole untapped area of distress, kind of a whole disenfranchised population of elderly, debilitated people who have pain that can't get help. And it's not sexy, but it's important. So I found it really rewarding. And then one day I got a phone call from a local hospice agency. And up till then, I really wasn't familiar with hospice. But they said, we really like what you're doing with pain management. Would you mind helping us with hospice? And I said, why not? I had a half day off a week, so I thought, sure, well, go down and try that. And darned if I didn't find in hospice what I got into medicine to do. It was just every patient needed attention. And I'm not to demean certain things, but when you spend your day just cranking through patients who have a little rash, a little stomachache, or I've got this headache, or the patient that came in every 2 weeks with a diary of every bowel movement she'd ever had, I'm just like, okay, this is not as rewarding as I was hoping my practice would be. But I found hospice to be remarkably rewarding. Patients so grateful when I was doing home visits. They just astonished that a doctor would come to see them. And I kind of slowly increased my hospice time and decreased my clinic time. And kind of push came to shove, and there came a point when the clinic came and they said, hey, you're either with us or you're not with us. You need to make a choice. And at that time, the hospice I was working for, which was a national hospice, invited me to go full-time with them. I ultimately became their chief medical officer and just fell in love with what I was doing. Time goes on, that company got bought, careers changed. I worked with a number of hospices. We wanted to stay where we lived, which was in northern Utah, which has over 90 hospices just in the northern area. So nobody can afford full-time. And so doing that part-time, and I worked as a hospitalist full-time to pay the bills. But I really did not enjoy being a hospitalist because I couldn't not do essentially palliative care. I couldn't not have the family meetings to talk about it. So I was working over my time. Hospice was my focus for many years. I was asked to do a job in Davenport where I was actually hired to be part of an inpatient hospice program. And literally on the way out, the chief medical officer of the hospital went to a conference and found out that every hospital worth their salt had inpatient palliative care. So they changed my job description as I was traveling. Oh, by the way, we need you to set up a palliative care program in our hospital. And that was news. Again, I had a nurse practitioner who was very good that I worked with, and I helped train her, so she ultimately got board certified. And we had a really good program going. We went through COVID, and everyone knows how horrible that was. As a palliative care doctor, I was essentially living in the ICU and all the gear. It was very challenging, but even more challenging because palliative care as a entity in a hospital, if you just look at the silo, it doesn't make money. There are lots of studies that say it saves the hospital money, it increases patient satisfaction, it decreases readmissions, but doesn't make money, and the financial crunch on that hospital, they ultimately discontinued the program. And so various things happened, and now I'm here, and this is a hospital that gets it. They contract with the company I work for to provide palliative care, and things are going very well. That's how I got here. I love what I do.
That is so great to hear, and it certainly is important work. These are often a lot of patient populations that have been dismissed by the rest of medicine. Their pain has been invalidated, and so it is so incredibly important, the work you are doing, seeing these people and helping them to live their life to the fullest. And that reminds me of a quote of yours that I actually came across that said, palliative care is not about giving up hope. It is about living your life to the fullest. And that really resonated with me. And something else that I've seen a lot about is that misconceptions about what hospice and palliative care is often prevent people from accessing these crucial services. And it's misconceptions on the general public side, but it's also misconceptions from healthcare professionals. Are there any misconceptions that you would like to specifically address?
So it's a very common thing that people have never even heard of palliative care, and if they have, they tend to think of it as hospice. And what I do is I describe it, palliative care as being like a basket of fruit, and hospice is an apple in the basket. So it is a part of palliative care. It's like, as you might say, the tip of the spear. But palliative care moves quite a bit upstream. You don't have to be approaching end of life to receive palliative care. I've been consulted to just do aggressive pain management with post-op patients who were nowhere near end of life. When I go in to see a patient in the hospital, I tell them that palliative care has three primary goals. The first is we are trained in aggressive symptom management, that we are the most holistic of medical specialties, because I'm not looking at heart or lungs or feet. I'm looking at that person and how can we improve their quality of life and be more aggressive about managing their symptoms. So that's the first thing. The second thing is, because we have a little more time than a hospitalist and a little more expertise, we help them to have some of the difficult conversations that people don't like to have, they tend to put off or never have, but that it's important that we do have those conversations. And so that's one of the main things I do. And the third thing I explain is that we provide communication. 9 times out of 10, when I go into a patient's room and I ask the patient or family, what is your understanding of what's going on? The answer is, we don't know. Or it's very optimistic or doesn't include everything. And there are a lot of reasons for that. Many of these patients are elderly. They're often hard of hearing. They're sleep deprived in the hospital. They're sick. People are constantly coming in and out. Hospitals are scary places. Whether you're elderly or not elderly, if you're not familiar with the system, it's scary to be in a hospital. It's scary to be sick, and it's very disorienting. So we try to ease them through that process. And that seems to help. They get what we do. It's not just, hey, we're here because you're going to die. I preface my end of life, my goals of care conversation with, I have this conversation with everybody. I'm not predicting that you're about to die. We don't think you're about to die, but we do know when you're 83 and have multiple medical problems and you're in the hospital, things can happen abruptly. And we'd rather talk about it ahead of time and have it not happen than be surprised,
Yeah.
And so that's kind of where palliative care is.
Yeah. And that, what you just said reminds me, I just came across this quote that said, it's important that we destroy the myth that telling the truth destroys hope. And I feel like that's incredibly applicable. Have there been any particular patient encounters or moments in your career that have been just deeply impactful to you personally or professionally?
Oh, it's
Too many to count, I'm sure.
I will say, so palliative medicine is not for everybody. I mean, there's a lot of emotion here. I had a patient die today. Shortly, I talked with the family. They had just moved here to be close to another family member. He suddenly decompensated. I went in, I talked with him. I was able to say, look, he's close. He's within minutes to hours. And he passed. And I had really kind of bonded with the family a little bit, and it was hard. It was just very hard. There's a fine line of sufficient empathy, which is what's often missing in physician-patient-family interactions. Many doctors are not very skilled interpersonally. They can come across as quite abrupt, they can be short. I always go into the room and sit down so they know I've got time. And what I do for me, I actually view it more as a ministry than a medical profession, because I'm addressing spiritual things, emotional things, as well as physical things. I saw a patient yesterday, elderly lady came in with a fractured hip, and she came in with, she had fallen and had a subdural hematoma, and the scans showed almost certainly she had metastatic lesions all through her spine. And when she fell, she hurt her knees. And she had some memory deficit, but wasn't what you'd call dementia, And when I said, what's going on with you? She said, I bumped my head. They told me I've got some blood in there, but it's okay. And my knees really hurt. And I said, have they told you anything about your scans? No, what? So I had the privilege of easing her into the fact that she probably had cancer. And no one had brought that up with her before. And that is a remarkably emotional moment for someone to hear they almost certainly have a terminal illness. That's always impactful. And I go clear back to when I was a second-year medical student. In our last quarter, we actually started our rotations, and I did surgery. And on rounds one day, the attending physician said, biopsy came back. This guy's got cancer. It's inoperable. And he told me, the medical student, at the end of his second year, he said, go in and tell him.
Wow.
And I just thought, and I did that as best I could, but that has never left me. That, how dare you take such an important conversation and just delegate it to someone who has no experience, no understanding, no training. We have the opportunity to be with patients at very sacred times in their lives. Dying is a very sacred moment. And it is very, special is probably not the right word, but for families who are there, it is something unique and emotional, and often very spiritual, and that we are privileged to be a part of that is it's a gift, but it's not a gift that everybody can take in. So really, almost daily, I have experiences. I will tell you the funniest thing that ever happened to me. While I was working with hospice, we had a patient who was in his 60s, generally healthy, who for no apparent reason just basically went into a coma. And they could never figure out what happened to him. And this will kind of date me as to when this was, but so he was at home, pillar of the community, a very religious man, huge family. And I happened to be there when he started showing signs that he was rapidly approaching death. And he started, oftentimes before death, and usually it's not right before death, but we call it the golden hour. Kind of like that burst of energy you get before you deliver in pregnancy.
Right.
People sometimes perk up and do things, and that's hard on families because they think, oh, he's getting better. Well, he started moving a little bit, which he hadn't been doing. And I said, hey guys, come on over. This may be our chance to, maybe your chance to spend a little time to say something. He sat up, hadn't done that for weeks and weeks. He looked around and he said, damn you, Bill Clinton, and died. And the family was just, he'd never been very political, never been someone who would curse.
Yeah.
That was his last words for his family. They did not put that on the gravestone, I don't believe.
Oh my goodness.
But, you just never know what's going to happen. You just never know what you're going to encounter as you go through this. We interact with families at some of the most stressful times of life.
Absolutely.
And, things happen. It's funny. It's sometimes tragic. It's most frequently emotional.
Yeah.
But the reward of seeing somebody get out of pain. I actually had a neighbor who was getting treatment for cancer that was metastatic. And she came onto the hospice I was working with. And she had been a real go-getter and was just exhausted and constantly in pain. And I addressed her pain with extended release. I put her on a little bit of a stimulant. And literally the next week, she was a new person. And she said, why didn't anybody do this for me before? If it could be done so quickly and so easily, why has nobody done this for me?
Yeah.
Well, I mean, that's an indictment of the system, but it's also very personally rewarding for me to know that I was able to make that much difference in a patient's life and improve the time that she had left. So it's
absolutely
all rewarding.
Yeah. I mean, your job is certainly one that requires a lot of emotional labor, in addition to all of the other support you provide. So to wrap us out, do you have any pieces of advice for students who are entering the health professional space now and who might begin careers in hospice or palliative care or across any medical specialty? But what advice do you have on how to best interact with patients, how to deal with the emotional labor that comes with health professions?
I think the key is don't go in like you're the expert. Don't judge. Again, you often hear people say, oh, this husband is a jerk. What does he know? We don't know. People in crisis aren't the people that they are not in crisis. So we don't judge. Have empathy for what's going on. Listen. And most of all, if you don't know what's happening, ask for help. There's just there are a lot of doctors out there, and because I've seen their patients who think they're hot stuff when it comes to pain management, and they're not. Ask for some help. And again, that's my area, but in any other, don't pretend to be a cardiologist. If you're not, send them to somebody who is an expert. Your patients deserve the very best they can get. And it's not anything negative about you. Nobody can know everything. Be willing to ask for help and know what you don't know. So we all have to, I learn things constantly, and I've been doing this for over 20 years. So you just always have to be humble enough to be teachable. Yeah.
Well, thank you so much, Dr. Chamberlain, for coming on and sharing your story and expertise with us. I really appreciate it.
It's been my pleasure. Thank you for inviting me.
And that's a wrap for this episode of Future of Caregiving, brought to you by Care Yaya. We hope you've enjoyed this exploration into the world of caregiving and that you've learned something new and valuable. If you want to stay up to date on all things caregiving, be sure to subscribe, rate, and review. And don't forget to check out careyaya.org, where we're dedicated to improving the future of caregiving through technology and compassion. From all of us here at Care Yaya, thank you for tuning in.